Hello, everybody, and welcome back to part 30 of our internal medicine review questions. Now, after this video gets put up, I am going to start making psychiatry videos for review. So you've got these 30 internal medicine review videos. That's 300 questions. That should set you up pretty nicely. Now, I want to point out, I know that this wasn't the case when I was in medical school, but it is the case now, that medical students today are using Anki cards. And while that is really good for memorization, it's not going to help you in the hospital. It's not going to help you. You need to understand how to work through this intuitively and get that clinical judgment. Because if you just memorize flashcards, it's going to help you for the boards, but you're going to be in a lot of trouble in the hospital because the hospital is not about memorization. Patient care is not about memorization. That gives you the groundwork, but you need to understand how to reason through these things rather than just rely on brute memorization. And so that's kind of what I take you through with these questions, is helping you understand how to work through the questions. You may have some of these answers memorized, but the test isn't quite that easy. It's not a fill-in-the-blank test, okay? So a little bit of advice there. If you haven't had the chance yet, please consider subscribing to my Patreon. You can get there by clicking the link in the description of the video or in the I button on the upper right-hand corner. I very much appreciate all the contributions that I can get to help offset the cost of these videos, and I thank all those of you very, very much who have already donated. All right, let's start with question 1. 38-year-old woman presents to the clinic complaining of worsening abdominal pain and watery diarrhea for the past 2 weeks. She's got a past medical history of Crohn's disease, which has been well controlled for the past 5 years with adalimumab. She does not smoke, drink alcohol, or use recreational drugs. She recently received a levonorgestrel IUD, but is on no other medications. Vitals are more or less within normal limits with a slightly elevated temperature. Physical exam is remarkable for mild right lower quadrant tenderness to palpation, no guarding or rebound. Labs reveal undetectable adalimumab levels. Which of the following is the most likely explanation for this patient's presentation? A, increased metabolism via the cytochrome P450 system. B, development of anti-drug antibodies. C, formation of insoluble complexes at the injection site. D, malabsorption of adalimumab. Or E, inadequate adalimumab dosage. All right, so this is a little bit of a tough one here. All right, let's go ahead and answer this question. The answer is B, development of anti-drug antibodies. This is something that happens particularly with biologics. Those monoclonal antibody drugs, they are foreign. And so you will mount an immune response to them occasionally. And when that happens, you will develop antibodies. And that's exactly what's going on here. You're taking adalimumab, okay, Humira. And despite the fact that you're taking it, you have none detectable in your blood. That tells you that that is going somewhere, and it's actually being destroyed by your immune system as it's recognized as foreign. And so this is something that can happen with these biologics, and there's a very complex reason why it happens. I'm going to run you through that really quick. It's going to give you flashbacks, maybe PTSD flashbacks to step 1, but we'll run through it fairly quickly. Why is A wrong? Increased metabolism via the cytochrome P450 system. So this patient is only on one drug, okay, levonorgestrel, and it does not induce the cytochrome P450 system, so that's out. Furthermore, adalimumab is not metabolized by the P450 system anyway, so that's out. Formation of insoluble complexes at the injection site. What does that? Insulin glargine can do that, forms insoluble precipitates at the injection site. That's actually a good thing. That's a good thing because it allows that insulin to very slowly dissolve, and that's what allows insulin glargine to have a very long duration of action. And it's actually the only one that does that. Other long-acting insulins use a different mechanism. What about D, malabsorption of adalimumab? Do you take adalimumab as a pill? No, it's a subcutaneous injection. What about E, inadequate adalimumab dosage? Well, you should have some adalimumab with the dosage that she's on. It was working for 5 years. And so something happened where she doesn't have this in her body anymore. So that's out. Okay, so there's anti-drug antibodies. Now let's run through the fun stuff. So this is how anti-drug antibodies develop. So first of all, the drug is broken down and it is presented by the antigen presenting cell right here. And as it's presented, the T cell will become activated. Okay, so you have your MHC and your T cell receptor. And when that T cell, that helper T cell is activated, it makes cytokines, particularly cytokines like interleukin 4, interleukin 5, interleukin 13. And what that does is that cell then becomes activated. And when that cell becomes activated, it will receive that same antigen and activate the B cell that will then make the antibodies in question here, particularly IgM antibodies. Now, you might remember that the activated T cell, and we don't see it here, but you've got on the activated T cell, you've got CD40 ligand, and on the naive B cell, you've got CD40. Okay, remember the clinical implication of these? Remember hyper IgM syndrome where there's a mutation here and this process can't happen, so you don't develop plasma cells and you don't get class switching? That is an important mechanism for you to know. Remember hyper IgM syndrome, it's an X-linked recessive disorder, and if you can't do that, you can't class switch. So then we go to the plasma cells spit out anti-drug antibodies, and that's going to neutralize the Humira. Okay? All right, question 2. A 66-year-old man presents to the ED due to bloody stools. Over the past few days, he's noticed small amounts of blood on the toilet paper and in his underwear, but this morning the toilet was filled with blood. He's got a history of irritable bowel syndrome with constipation. He takes psyllium husk on a daily basis and says that he has 1 or 2 bowel movements per day with no abdominal pain. No other medical issues. He's on a daily low-dose aspirin. Vitals 122/78, heart rate 65, respirations 12, temperature 98.6. Physical exam is remarkable for grossly bloody stool, no rectal tenderness. Nasogastric tube is placed and shows copious amounts of bilious fluid. CBC, BMP, and INR are ordered and are as shown. We'll show you that in a little bit. Which of the following is the best next step to the management of this patient? Let's take a look at our labs. Okay, so here you have it. So take a look here. What's abnormal? Remember, you can compare this to your lab handout. You will be given this on your exam. Okay, let's look at our answer choices. So what's going on with this guy with bloody stools? What are we going to do next? Okay. Is it A, EGD, B, arrange for capsule endoscopy, C, arrange for colonoscopy, D, angiography, or E, start IV octreotide? All right, so let's go ahead and answer this question. The answer is C, arrange for colonoscopy. All right, so we got this guy coming in saying that there's blood in the toilet. Now, I'll tell you this. Patients get really freaked out and they see a toilet full of blood. All it takes is 3 or 4 drops of blood to turn the entire toilet red. Okay, and especially here in the United States where we put a lot of water into our toilet, and you're going to see all this red water. It doesn't take much. Okay, your blood's full of pigment. So that often scares patients, but what we really want to know is how much blood, and we don't necessarily know that. Okay, we don't know how much blood is going on here, but look at this. Copious amounts of bilious fluid that was taken out of the stomach. What does that mean? That means there's no bleeding in the esophagus, there's no bleeding in the stomach. So this is either coming from colon or from small intestine. Okay, now, it is possible to have bright red blood per rectum, or at least maroon blood, if you have a very brisk upper GI bleed, but that's very unlikely here. He doesn't have any risk factors for that. He doesn't drink alcohol as far as we know, so the idea that he may have varices is pretty unlikely. So let's look at A, EGD. Why not? We would do that if an upper GI bleed were suspected. And here the NG aspirate is not bloody. The patient is stable. If this patient were, had a very low blood pressure, we had to give him fluids, we might go ahead and do an EGD very quickly to see if perhaps there's any bleeding varices, because we can address that right away. But that's not what's going on here. This patient is stable, and so the next step is a colonoscopy. Capsule endoscopy. That would be something you would do if you did an EGD and a colonoscopy and you couldn't find the bleeding. The capsule is going to help look at the small intestine. Angiography. Angiography is going to be done for unstable patients if the EGD fails to identify the source. Okay, so unstable patients. The way that you work these patients up with a presumed lower GI hemorrhage is going to be different depending on whether the patient is stable or unstable. And that goes for a lot of things in emergency medicine. And I've got a little algorithm that will help you with that. I'll show you in a little bit. Okay, IV octreotide, when do we use that? Bleeding varices. He doesn't have bleeding varices, because if he had bleeding varices, we would certainly see it in the NG aspirate. Okay, so it is arranged for colonoscopy. So here's your little algorithm here. You've got a patient with hematochezia that typically is going to be either maroon blood or bright red blood per rectum. And you ask, is the patient stable? In other words, you look at their blood pressure, you look at their heart rate. If their blood pressure and heart rate are in the normal range, they're stable. If they're hypotensive, tachycardic, then they're unstable. Now, this is unstable or a GI bleed is suspected. So if they have hematemesis, if you aspirate through the NG tube and you find coffee ground or you find bright red blood, then we would go down this road here on the right. Okay, so this patient was stable. He's got hematochezia. We're going to send him off for colonoscopy. Now, he's going to have to prep. He's going to have to go through all that. It's going to take 12 to 24 hours, but we will be sending him in for colonoscopy. If the source isn't found, go ahead and do the EGD. You probably won't find anything there, and so at that point, you will go forth with a capsule endoscopy. Now, if they are unstable, of course, our next step is to resuscitate them. That comes first. You give them fluids, get their blood pressure up, go ahead and do the EGD, consults as needed, and then if they are still unstable, it's going to be angiography. We'll help you find the bleed fairly quickly in most instances. If you have stabilized them, which in most cases you will, then it's going to be the same as over here. You're going to do colonoscopy. If the source isn't found, since you already did your EGD, you'll go ahead and do the capsule endoscopy. Okay? Question 3. A 35-year-old woman presents to the clinic complaining of right calf pain and swelling for the past 3 days. She was admitted to the hospital 2 weeks ago for acute deep vein thrombosis on the same side. 10 days ago, she was discharged after achieving an INR of 2.5. Past medical history includes migraine headache and 2 miscarriages at 14 and 16 weeks. Lupus anticoagulant is positive. Medications include warfarin, rizatriptan is needed, and a prenatal vitamin. Vitals show blood pressure 132/83, heart rate 94, respirations 12, temperature 98.6. Her BMI is 37.2. Physical exam reveals tenderness and swelling of the right calf. Left calf is unremarkable. INR taken today is 1.2. Duplex ultrasound reveals femoral vein thrombus unchanged from her previous admission. Which of the following is the best next step in the management of this patient? A, increase warfarin dosage and recheck INR in 2 days. B, start enoxaparin and increase warfarin dosage. C, add apixaban to current regimen. D, catheter-directed thrombolysis, or E, referral for IVC filter placement. Okay, let's go ahead and answer this one. All right, so we're going to start her on enoxaparin and we're going to increase the warfarin dosage. So why can't we just increase the warfarin dosage? Because if you have more warfarin, it's basically like giving them warfarin in the first place. Remember, we never just start a patient on warfarin. Remember, protein C and protein S, which are anticoagulative, they're the first ones that are going to get knocked out by warfarin. And so you're going to have a temporary period of time where you're hypercoagulable. And that is something we do not want in this patient who already has a DVT going on. So we're going to start the enoxaparin, and then we will increase the warfarin dose, okay? So when you've got a patient with a DVT, a subsequent DVT, you treat it like a fresh DVT. So you're treating this the exact same way you would if she came in for the first time. All right. Now, increase the warfarin dose and recheck INR in 2 days? No, she may come back with warfarin skin necrosis. We don't want that. Add apixaban to the current regimen? No, 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 no. You never combine warfarin with an oral anticoagulant, with apixaban, for instance. Apixaban is okay in antiphospholipid syndrome, which this patient has, without thrombosis. But in this patient, we need to go heparin, warfarin. And that could be a low molecular weight heparin, or it could be unfractionated heparin. Remember, though, what if the patient has renal failure? Do we give unfractionated or low molecular weight? Unfractionated. Unfractionated. The kidneys get rid of low molecular weight heparin. If the kidneys aren't working, you're going to build that up, build that up, build that up, and they're going to bleed. Okay, so that's out. Catheter-directed thrombolysis. Only if the limb is threatened. If there was compartment syndrome, phlegmasia ceruleus dolens, if there was numbness, if the limb was cold, we don't see any of that here. Referral for IVC filter placement? No. We do that if anticoagulation is contraindicated. If there was a recent surgery, if there's a recent history of hemorrhagic stroke, something along those lines. Okay, so it is B. This patient has antiphospholipid syndrome. How do we know that? Okay, so there's two things that need to be true in order to have antiphospholipid syndrome. Number one, you need to have a history of some sort of clotting issue. So a vascular thrombosis, that's this patient, she's got a DVT. Okay, or if you got a woman, it can be a pregnancy complication, and there's a number of, you can go and look this up if you want. So, well, you know what, I'm just going to give it to you since we're already here. So what do we mean by pregnancy complication? Typically what they're going to say is the patient has had multiple miscarriages, but the actual definition is going to be one or more unexplained fetal deaths at more than 10 weeks gestation. Or it could be more than at least 3 consecutive spontaneous abortions at less than 10 weeks. That's just a miscarriage. Or it could be at least 1 preterm birth at less than 34 weeks gestation that's secondary to preeclampsia or, that's severe preeclampsia, or eclampsia, or placental insufficiency. Now, on your test, technically, I guess you need to know this, but they're probably going to tell you that the patient has repeated miscarriages. This is probably the one they're going to give you. Okay, unexplained miscarriages, 12 weeks, 15 weeks, 18 weeks. That was this patient, 14 and 16 weeks. All you need to actually have is 1, but she had 2, and that's typically how they're going to present. Usually when a woman has a miscarriage the first time, you think, well, that's just bad luck, because a lot of pregnancies end in miscarriage, and we don't really talk about it a whole lot. But if you start to have 2 or 3 or 4, that's when you start to think maybe there's something wrong. And if you satisfy this, and this is an OBGYN thing, if you've got a patient with recurrent miscarriages, you need to check for antiphospholipid antibodies. That could be anticardiolipin, lupus anticoagulant, anti-beta-2 glycoprotein. Check for all 3 of them. If one of them is positive, then boom, you've got your diagnosis of antiphospholipid syndrome. The treatment is heparin and then bridge to warfarin. Okay, and that will help her perhaps successfully carry a pregnancy to term. Okay, question 4. A 27-year-old man presents to the clinic complaining of hair loss. By the way, this will be 4 through 6. Okay, so we've got 2 follow-ups after this. Last week, his barber noticed a small patch of hair loss, and the patient is concerned that he has cancer, as his father developed colon cancer at age 41 and has Crohn's disease. He has no significant past medical history and is on no medications. He doesn't drink alcohol, smoke, or use recreational drugs. He is monogamous with his female partner. Occasionally, they share a comb for brushing their hair. Vitals are within normal limits. On physical exam, you note a single 1.5 centimeter ovular patch of complete hair loss with distinct margins. There's no inflammation or scaling present. Which of the following is the most likely diagnosis in this patient? A. Colonic adenocarcinoma. B. Squamous cell carcinoma. C. Tinea capitis. D. Discoid lupus erythematosus. E. Alopecia areata. Or F. Androgenic alopecia. Okay, so go ahead, lock your answer in here, and we're going to move on to the next one. Which of the following statements is true about this patient's condition? A, he must be tested for a mutation of the MSH2 gene. B, he should refrain from sharing a comb with others. C, he should be prepped for colonoscopy. D, this condition can recur despite treatment. E, medications can completely cure this condition. F, this is an autosomal dominant condition. Or G, this is an autosomal recessive condition. All right, so go ahead and pause, and we'll move on to the next one. All right, which of the following is the most appropriate management for this patient's condition? A, resection of the malignancy if present. B, oral prednisone. C, intralesional corticosteroids. D, topical tacrolimus. E, griseofulvin. F, topical corticosteroids and oral hydroxychloroquine. G, finasteride. Or H, minoxidil. All right. So we're going to go back now to question 4, which was basically asking the diagnosis. This is alopecia areata. Okay, now we don't see a whole lot of this. My dad actually had this as a fairly young man. I think he was probably 35 years old, about my age. So I was very scared I was going to develop this eventually because, it's my dad. I did not, but he did develop this, and he's been bald ever since. So alopecia areata, you lose your hair completely, but just in little patches. Okay, so you'll have a guy's hair like this, and there'll be little areas like that. And usually it's in a guy, but it can be in a woman too. A lot of times with women, their hair is long enough that it'll cover it up, and it's a little bit harder to notice. But it could be either. So he's got a small patch of hair loss. He's concerned he's got cancer. Okay, does cancer make you lose your hair? Well, some people think yes, but no. Chemotherapy causes you to lose your hair. So this is something you're going to deal with patients who don't really understand how the body works, and that's okay. And it's your job to not judge them, not laugh at them, but to reassure them and explain to them that cancer would not cause you to lose your hair. Okay, so cancer is not the answer here. Tinea capitis. So tinea capitis can cause patchy hair loss. However, what you would see is scaling, you would see inflammation, you would see little bits of the hair follicles that have broken. You may see a little bit of regrowth. And so it's not smooth. It's not, you're going to have inflammation and scaling. And so that is quite different. Remember, tinea capitis is a fungal infection. Certainly could come from sharing a comb with someone, but we don't hear anything about the female partner having hair issues. So that's out. Discoid lupus erythematosus. What is that? So that's basically lupus skin features without the systemic symptoms, without the fatigue or the fever or arthritis or nephritis. Their urinalysis is going to be normal. The ANA in discoid lupus is absent 70 to 80% of the time. So a lot of times you're relying on a skin biopsy to distinguish discoid lupus. All right, that's a tough one. Okay, it really is. And then androgenic alopecia. What about that one? So androgenic alopecia will start frontotemporal, and this is going to be on men. Frontotemporal, so they start to develop kind of a widow's peak. So if you're looking at the top of their hair, you'll see kind of that. And then eventually they will start, in many cases, to develop this occipital hair loss, and then it just gets worse. It recedes and recedes and recedes, and eventually they're bald. Okay? My grandpa had that. I fortunately do not yet. Okay, so it is alopecia areata, and you really need to know the difference between that and tinea capitis is always going to be one of the wrong answers with that, and it's the inflammation and the scaling that will give that away. Now, this patient is 40, this patient's 27. His dad had Crohn's disease and developed colon cancer at 41. What does that mean? By the way, this is kind of a GI tangent. Well, you need to get your colonoscopy at either, if you have a first degree family member, you need to get it at either 40 or their age when they had the cancer minus 10, whichever is sooner. So he needs to get it either at 40 or dad's age, 41 minus 10 is 31. So he needs to get it at 31 years old. So you're telling this man, hey, by the way, in 4 years, you need to come in for a colonoscopy. Normally it's 45. But in this case, it is going to be 37. Now, I'm sorry, 31. Now, if the first degree family member was 51, you would still do it at 40. So the age goes down if there's a first degree family member with colon cancer. Okay, now, which of the following statements is true about this patient's condition? This condition can recur despite treatment. Okay, so treatment will help you, but it can come back. There's really no cure for this. Okay, it is autoimmune. Now, what about A? MSH2 gene, what is that? Lynch syndrome. Now, Lynch syndrome can cause colon cancer for sure. It can cause ovarian, endometrial, but that's not the case here. He doesn't have colon cancer. He doesn't have any of the symptoms of colon cancer. He should refrain from sharing a comb with others. That would be if there was a contagious problem going on, like tinea capitis or head lice, for instance. Okay. He should be prepped for colonoscopy. No, we know that. Medications can completely cure this condition. Nope. Autosomal dominant, autosomal recessive. No, this is probably polygenetic. Okay. So it is D. Okay, and then question 6 is basically just asking you what's the treatment for alopecia areata, and the answer is intralesional corticosteroids. What other disease or process do we use intralesional corticosteroids for? It comes up. We would use it for keloids. Remember all that hypertrophic scar tissue? You can use intralesional corticosteroids there. Okay, so these should be pretty obvious why they're wrong. Resection of the malignancy, he doesn't have one. Oral prednisone. So you can actually use oral prednisone in patients with alopecia areata, but it is not our first line. Remember, you're taking prednisone, it's got all sorts of negative side effects. Bone loss, Cushing's, you name it. Topical tacrolimus, actually same thing. If there's more extensive loss, you can do this, but we're going to start with intralesional corticosteroids. Remember, he only had one little spot, so we can just do that spot. If it's 50% or more, then you would start looking at topical tacrolimus, prednisone. Griseofulvin, that's for tinea. Topical corticosteroids and oral hydroxychloroquine, what would that be the answer for? That would be if this was discoid lupus, okay? Topical corticosteroids, oral hydroxychloroquine, no, not for COVID, not for COVID. Hydroxychloroquine has a number of uses. It's used in autoimmune disorders, but it is not going to be used here. Hydroxychloroquine has a major side effect too. And what is it? Do you know? Retinal toxicity, okay? That's why those dummies who are taking hydroxychloroquine for COVID were really taking a big risk there. Try to contain my language. Finasteride, minoxidil, both for male pattern baldness. Okay, so we made it through. So this is alopecia areata, autoimmune attack on hair bulb cells. It is a genetic predisposition. Fortunately for me, I did not get it from my dad so far. Painless, patchy, non-scarring hair loss is just going to look like pure scalp, okay? They got a little patch or they look like Mr. Clean. Clinical presentation, painless, patchy, non-scarring hair loss. There's a hair pull test you can try. That's not going to be tested. Management, mild or moderate. You're going to use topical or interlesional corticosteroids. If the hair loss is extensive, topical immunotherapy like tacrolimus or oral corticosteroids. Many of these men will just shave their hair off rather than going in for steroid injections all the time. Okay, question 7. An 18-year-old man presents to the clinic complaining of worsening rash for the past week. He says that last week he had the flu, during which he had a low-grade fever and a cough. Shortly after that, he developed the rash, which started on his face and then spread to his chest and extremities. He works as an aide in a kindergarten classroom. He denies sick contacts. He has a past medical history of systemic juvenile idiopathic arthritis and takes methotrexate and a multivitamin. He is sexually active with both male and female partners and uses condoms inconsistently. He is unsure of his vaccination history and says that his parents are hippies and don't believe in vaccines. Vitals show blood pressure 119/79, heart rate 109, respirations 18, temperature 101. There is a diffuse papular and vesicular rash with some lesions crusted over. Bilateral crackles are heard on auscultation of the lower lung fields. The remainder of the exam is unremarkable. Which of the following is the most likely diagnosis in this patient? A. Varicella, B. Rubella, C. Mycoplasma pneumonia, D. Herpes simplex, E. Coxsackie virus infection, or F. Acute HIV infection. All right. So let's go ahead and answer this one. It is varicella. Okay, now the giveaway with varicella, and they may give this to you or they may not, but the classic giveaway is multiple vesicular and papular lesions in various stages of healing. You're not going to have a confluent rash where all the little lesions of the rash look the same. Okay, you know what chickenpox looks like. Most people have gotten it, unless you've gotten the vaccine. I don't know, actually. You know, some of you might be younger than me. When I was about 5 or 6 years old is when the varicella vaccine actually came out, back in the mid-90s. But you might not see it as much anymore, but it does happen, and you need to know what it looks like. Rubella. So what kind of rash would we have with rubella? You'd have a maculopapular rash, not vesicular. Now that rash is going to spread cephalocaudally like this patient's. Varicella doesn't necessarily do that. But you would also see something else in rubella, post-auricular lymphadenopathy. Okay, and another thing, when you got an adult patient with rubella, they also have another feature, arthralgias. Their joints hurt. You don't see that in children too much. Mycoplasma pneumonia. So that is an atypical pneumonia. This patient indeed has crackles heard on auscultation. I probably should have made that red too. But mycoplasma pneumonia is, if it does have a rash, it's going to look more like erythema multiforme. It's not going to be vesicular. Okay, so you may have like a target-looking lesion or something like that. D, herpes. What about herpes? So you will get vesicular lesions here. They're going to be painful. Usually they're going to be oral or genital. It is not going to give you a pneumonia-like picture, okay? Coxsackie virus infection. What does that cause? Certainly you can get this from kindergartners. Hand, foot, mouth disease. So you would see the rash primarily, of course, on the palms and the soles and the oral mucosa. Okay, we see it all over here. Acute HIV infection. Now, this is a tough one. This kind of masquerades as a lot of things. So acute HIV infection, certainly this guy is at risk. He doesn't use condoms consistently. But acute HIV is going to look like mono. Okay, you're going to have someone coming in. A lot of times they're going to be 20, 30 years old. Maybe they had mono in the past, and it looks like they've got mono. And it looks very similar to mono. You can get a rash, you can get flu-like symptoms, you can get generalized lymphadenopathy, splenomegaly. It looks very similar. You may do a mono test, it comes back negative, and you might think, maybe I need to check this guy for HIV. So it is something to consider. However, the rash that comes from HIV, from the acute HIV infection, is going to be flat. It's not going to be vesicles. Furthermore, they tend to have flu-like symptoms with the acute HIV infection. Fever, nausea, vomiting, diarrhea, and of course the generalized lymphadenopathy. We do not see that with this patient, okay? So the answer is varicella. It explains the rash. It explains the crackles that we hear in the lower lung fields. Now, why does this guy have a varicella pneumonia? Most people don't get that. He is on methotrexate. That is an immunosuppressant. Okay, so he is at higher risk. This guy is going to need to probably get varicella immune globulin before this gets worse. Okay, so you know this pathophysiology here. It's the VZV, transmission through contact or airborne, spreads like wildfire in schools. High risk, adolescents, adults, immunocompromised individuals, pregnant women, big deal there. Go back to your OB if you don't know that, and newborns. So if they're older than 1 and they're exposed to chickenpox, we can give them the vaccine. We do give them the vaccine at 1. If they are under the age of 1, then we need to give them varicella immune globulin. And that's because we cannot give the varicella vaccine to infants under the age of 1. This tends to start with a prodrome, fever, malaise. Sometimes it might be described as a cold. Very much viral features. Of course, the lesions are going to be in different stages. You have macules, papules, vesicles. I don't know if you guys have seen chickenpox as much as I have. I started my training in the early 2010s, and so I saw it a little bit more, but a lot of parents now are getting their kids vaccinated, thank God. Diagnosis, clinical, management, supportive care. However, this patient is going to need acyclovir because he is a high risk. He's got pneumonia. This is a complication. As you can see, superimposed infection of the lesion, pneumonia, encephalitis. These two in particular are going to get acyclovir IV. This patient will need to be admitted. The prevention for this, 2-dose series of the VZV vaccine, which we give at age 1 and age 4. So we give it at the newborn checkup. We give it before the preschool checkup, before they start kindergarten. Okay, question 8. A 60-year-old man presents to the ED complaining of shortness of breath. He began noticing this 2 weeks ago, but it has gotten significantly worse in the past 48 hours to the point where he is short of breath even at rest. He denies chest pain. He has a past medical history significant for hypertension, type 2 diabetes, and adenocarcinoma of the lung, which was successfully managed 3 years ago with platinum-based chemotherapy. Medications include metformin, atorvastatin, lisinopril, and low-dose aspirin. He doesn't drink alcohol, has never smoked, and does not use recreational drugs. He is not sexually active. Vitals show blood pressure of 88/62, heart rate 122, respiration 20, temperature 99.4. Blood pressure is 81/57 on inspiration. Physical exam reveals distant heart sounds and a mild jugular venous distension. Lungs are clear to auscultation bilaterally, and there's mild pitting edema. EKG is as shown. Bedside echo reveals a moderate pericardial effusion. Which of the following is the best indicator for surgical management in this patient? Let's take a look at his EKG. So here it is. All right, so go ahead and pause if you want to look at this more closely. And we're going to go back now. So what's the best indicator for surgical management in this patient? A, QRS complex amplitude. B, systolic blood pressure drop of 7 millimeters of mercury on inspiration. C, diastolic blood pressure drop of 5 millimeters of mercury on inspiration. D, early diastolic collapse of the right ventricle on echo. Or E, large V wave in the jugular venous pulsation. All right, I purposefully made this one a little bit more difficult because it's very important, and I want to do this with you. I want to run through the wrong answer choices because that will help you understand why the right one is right. And when you're going through your test bank, you want to make sure you know why each of the wrong answers are wrong, especially the ones, if you look on like UWorld, where like 35% got one of the wrong answer choices wrong. You want to know because maybe you might have screwed that up too. Okay, so let's go to the answer here. Here's your EKG again. Early diastolic collapse of the right ventricle on echo. So what does this guy have? So he's short of breath. It's gotten worse. He is hypotensive, tachycardic, distant heart sounds, and then you do your echo and you see a pericardial effusion. So this is a guy with cardiac tamponade. Now, cardiac tamponade can be very sudden and kill you right away, or it can be very, very slow. Typically, the sudden ones are going to be from trauma, from a free wall rupture after an MI. If it happens suddenly, it does not take much fluid or blood in the pericardial space to cause cardiac tamponade. However, if it happens very, very slowly, your heart can adapt to that. And so you could look on chest x-ray and see this massive heart, or on echo, and you'd see this very large pericardial effusion. The fact that he has had this for a while, for a couple of weeks, lends us to think that this is a slower process going on. And we're concerned, particularly with his history of lung cancer, that this could be caused by cancer, in fact, and that can cause a pericardial effusion. Now, what about the QRS complex amplitude? Now, when you look at this, what's the one thing that stands out? Look at those QRS complexes. They alternate. The electrical complexes alternate. What's that called? Electrical alternans. Okay, electrical alternans. And that is very, very suspicious for a pericardial effusion. Basically, what's happening there is you have all this extra space in the pericardial sac, and so the heart kind of flops around there, and it causes these QRS complexes. Remember, the EKG looks at electricity in space, so if the heart is moving, flopping back and forth, you're going to end up with something like this. However, very important, you can have something that looks very similar to electrical alternans from other things. VTAC, SVT, Wolff-Parkinson-White, bundle branch blocks, electrolyte abnormalities. So you can get something that looks like that. That said, if you're looking at EKG and you're seeing electrical alternans, that patient is going straight to echo, because VTAC, SVT, Wolff-Parkinson-White, you're going to see that on your EKG. Okay, so you see electrical alternans, that patient is getting sent off for echo pronto. So the reason QRS complex amplitude is not the best indicator is because it's not as specific. What about systolic blood pressure drop of 7 millimeters of mercury on inspiration? What are we getting at here? Another feature that we see in pericardial effusion, we can see it, pulsus paradoxus. So you take a deep breath in, and normally your blood pressure will drop a little bit. And the reason for that is as you take that deep breath in, you're compressing the left ventricle. Less blood in there, less preload, less blood out, less cardiac output. Remember, blood pressure is cardiac output times systemic vascular resistance. Cardiac output goes down, blood pressure goes down, and that's how it's supposed to work. However, if it goes up more than that, what that's telling you is that there's something compressing the heart even further. So constrictive pericarditis, a barrel chest from COPD, asthma, pulmonary embolism can do it as well. Okay, so very, very important, but you have to be more than 10. So this guy does not have pulsus paradoxus. Diastolic blood pressure does not matter. Early diastolic collapse, that's the, why am I doing this here? Okay, here we go. This is the right answer, of course. Large V wave in the jugular venous pulsation, what is that? That would be seen with tricuspid regurgitation. I am not going to go over jugular venous tracings here. That is fairly low yield, but you want to take a look at that, your A waves and your V waves and all that. The two things you really want to know, though, with the jugular venous pulsations, you want to know your canon A waves, which is associated with a heart block, and your V waves, large V waves, which is tricuspid regurgitation. If you know those two, you're probably going to get your answers right. But if you want to look at that in more detail, go for it. So cardiac tamponade, blood in the pericardial space, or it can be a pericardial effusion. This patient likely has a pericardial effusion. Clinical features, Beck's triad, hypotension, JVD, distant heart sounds. This guy had that. Pulsus paradoxus can be there. This guy didn't have that. There's a number of reasons why someone might not have that. It's not, 100% sensitive, so you may or may not see it. EKG shows low QRS complexes and electrical alternans. So if you look back here, these are kind of short. Especially look at here at lead 1. You barely see your QRS complex. Chest x-ray will show an enlarged cardiac silhouette if it's subacute, or normal if it's very acute, because remember, you don't need as much blood to cause this if it's sudden. Echo will show right atrial and ventricular collapse because of all the extra pressure in the pericardial space. You can have IVC plethora as well. That's just that ruddy redness of the face. Management, IV fluids to increase the right side preload, increase the blood pressure, and then we need to drain this, okay? So if the patient is unstable, it's going to be a pericardiocentesis. You can do that right in the trauma bay or in the ER. Or if they're stable, you can wait, send them into the OR, and have a more definitive procedure done, which is the pericardial window. Remember, pericardiocentesis if they're unstable, pericardial window if they're stable. You will get both of those on your answer choices if they're going to ask you how to manage, and you need to know which one. So just think, OR takes a long time, pericardial window, you cut into them and all that, takes longer. Pericardiocentesis, it's just a needle. You can do it really fast. So that's for unstable. Okay, question 9. A 27, and this is going to be 9 and 10, by the way. See, I'm getting good at this. I'm not screwing this up again. All right, we got a 27-year-old guy coming into the ED for pain in his left, second, and third fingers. He was snowmobiling earlier this morning when his snowmobile broke down and he had to wait 4 hours for help. He was wearing a jacket, snow boots, and a hat, but no gloves. He has no medical issues and takes no medications. Vitals are within normal limits. On physical exam, the affected fingers are white, waxy in texture, and there is no sensation. Capillary refill is absent in the affected fingers, but present in the unaffected fingers. Technetium-99m scan reveals a perfusion defect in the left, second, and third fingers. Which of the following is the best next step in the management of this patient? A, apply a heating pad, and that's going to be to the fingers, by the way. B, rapid rewarming in a water bath at 98.6 to 102.2 or 37 to 39 Celsius. C, administer tissue plasminogen activator. D, apply manual friction. Or E, surgical referral for amputation. Okay, so go ahead and lock in your answer and we'll move on to 10. After appropriate management, there is no improvement. Technetium-99m scan. Did I do that? Okay, we're just repeating this. Technetium-99m scan is performed and reveals absent perfusion in the affected fingers. Which of the following is the best next step in the management of this patient? So we did our management that we were supposed to do. Now what? Rapid rewarming in a water bath at a hotter temperature. B, continue rapid rewarming in a water bath for an additional 15 to 30 minutes. C, administer tissue plasminogen activator. D, surgical referral for amputation. Or E, nifedipine. Okay, so let's go ahead and answer 9. The answer is rapid rewarming in a water bath. That is, so this is frostbite, by the way, in case you didn't know. And that is our first step for a patient with frostbite. Okay, we're going to stick their hands in a water bath. Now, I want you to know this. This is very, very important. If you're dealing with someone out in the wilderness and they've got frostbite and for some reason you've got access to hot water, which I don't understand why you would, you do not do this. Okay, you only do this when they're out of the elements, when they're inside. Okay, because if you do it outside, you're going to freeze their hand. That's the last thing you want, okay? So only do this when they're in the ambulance, in the hospital, inside, okay? Out of the elements. Now, why don't we apply a heating pad? Thermal burns, okay? Thermal burns. You want a nice, even warmth, not put your finger on a hot surface because you can burn yourself. Administer TPA. Nope, too soon. Apply manual friction. Tissue damage. Surgical referral for amputation? No. Okay, now if he needed amputation, you'd see necrotic skin. You would see skin that cannot be revived. You would essentially have terminal necrosis of the digit, and you would then need to amputate. This guy isn't there. He's got basically early frostbite, maybe frost nip. Okay, so it is B. And then the answer to 10 is TPA. Now, why is that? because we tried the water bath and it didn't work. So now we're going to do TPA. And we've got the technetium scan, and it shows that there's no perfusion in the affected fingers. So now we need to do something to get rid of whatever clot is there. And this isn't necessarily going to work, okay? But we got to try it. Rapid rewarming at a hotter temperature? No, you're going to burn yourself. Continue rapid rewarming in the water bath? Not shown to work. Surgical referral for amputation? No, he's not necrotic. Nifedipine, when would we give that for something that causes your fingers to go white? Raynaud. Okay, that's not the same thing. Okay, so it is administer TPA. So we got frostbite here. This can look a variety of different ways. Superficial pallor and anesthesia. That was this guy very, very early on. And then eventually, if this continues, you start to develop a blister. The blister will break and get an eschar. And then eventually get deep tissue necrosis and mummification. And that's when you have to go to amputation. This guy wasn't even close. Management, initial step, rapid rewarming and a water bath at roughly body temperature. If unsuccessful, you'll do the technetium 99M. I don't know why I put that here, to be honest. Actually, wait a minute. Why do I have this here? I'm sorry. I shouldn't have that there. But, you know, we did it anyway. So apparently when I went back, I deleted that. So my apologies. But let's just look at how we go through this. So rapid rewarming is our first step. If that's not successful, then we do the technetium 99M to assess for thrombosis. If you see thrombosis, you do thrombolysis with TPA. Okay? It's as simple as that. If you don't see thrombosis, then you can't do it, although most of the time you will see some thrombosis. And that's just because the blood gets really cold and you can form clots more easily that way. Analgesia and wound care, very important. These patients are going to be in pain, especially when the tissue starts to recover. Amputation, we talked about. Complications, all are associated, well, two of these are associated with tissue damage, ischemic necrosis, gangrene. That would be an infection on ischemic tissue. And then compartment syndrome, you'll have some inflammation. And so we often don't think of compartment syndrome of the fingers, but it can happen. So this is, you probably know, this is in Russia. And I went there about, oh gosh, how long has it been? About 6.5 years ago. New Year's 2018 to 2019. I went there. Now look at all these people standing out there with no gloves. Do you know how cold it gets in Moscow in late December? It was 10 degrees Fahrenheit. That's like minus, I don't know. I don't do Celsius. -5, -6, I don't know. Anyway, these people are not being very smart. And I hate to tell you this, but I was one of those people. So, you know, you get out there and it's warm and then you stand there. I mean, we got to Red Square at like, oh my gosh, 6 o'clock in the evening because we thought it was going to be packed. No, it wasn't packed at all. We walked around. About 10:30, it started to fill up. And by the time we got to midnight, it was packed. And it took us forever to get out of there. My fingers were so cold, I couldn't feel them. I couldn't move them. Frostnip, okay? Stupid. You know, sometimes doctors can be dumb too. This is a little bit of an illustration of, you can see here how you go from frostbite to frost nip. There's that little stage in between there where you can get that sort of pallor. Then you go to a superficial actual frostbite where you start to develop blisters. And then the deep frostbite is where you start to develop necrosis, okay? And this is just a little bit more here. This is beyond the scope of the steps, but if you want to look at this, you can. But what you really need to know is the treatment for frostbite, rapid rewarming. If it doesn't work, technetium scan, and thrombolysis can then be done if there is thrombosis. And thrombosis could be described to you as so. Capillary refill is absent. It could be described to you as a perfusion defect. They may not say thrombosis. You just have to gather that from the question. Okay, and that is it. We'll see you next time.